Hi, I'm Raj Gupta. I'm going to take you through how to interpret a normal chest X-ray and the search pattern I use to help me not miss any findings. It takes a lot of experience to actually put together the pathology and being able to detect it, but you need to start with a nice search pattern that you use every time so that you don't miss anything. So here we have a PA and lateral view of the chest. We're going to go right into the PA view first. And a mnemonic I like to use to first look at the technique is RIPE. The R stands for rotation. Here we basically look at the clavicular heads and make sure they're symmetric, so you can draw a line through the midline and another line through the medial clavicular heads, and you want to make sure that you make nice symmetric 90-degree right angles. Next we're going to look at inspiration. We want to see 8 to 10 ribs within the lung fields. Posterior ribs, so these are the posterior ribs that are more horizontally aligned. The anterior ribs are curved and slightly larger. So then we start counting 1, 2, 3, 4th rib, this is the 5th posterior rib, 6th, 7th, 8th, 9th, 10th, and we even can see the 11th here. So we have at least 9 to 10 ribs showing in the lung field, which is a great inspiration. Next is position and picture. So basically here we have a PA view, which is posterior to anterior. The patient is standing with their chest against the cassette, and the X-ray beam is shooting them from the back. This is the preferred view. It gives you the most detail, and it allows you to accurately evaluate the cardiothoracic structures. Another thing is that when the radiologist is reading the chest X-ray, they're reading it as if they're standing in front of the patient. So the patient's right is your left, and the patient's left is your right. So this is the right lung field of the patient, and this is the left lung field of the patient. You want to make sure that your technologist has marked the right side so that you know that this is the right lung field, or if they mark the left side, you want to confirm that that's the left lung field. Also, you'll see these dots within the technologist marker, and this can show you if the patient is standing upright, supine. It kind of helps you orient yourself, because certain pathologies show up differently based on the patient's position. The last part of RIPE is exposure or penetration. Basically, you want to see the spinous processes, you want to be able to see the vertebral bodies and the intravertebral disc space. In this case, we can even see the intravertebral disc space coming lower down, which means we have a great exposure here. So this is a great normal chest X-ray technique, and now we're going to go ahead and go through our search pattern. So I like to start in the right upper quadrant and go underneath the right hemidiaphragm, and here we're seeing the liver area. Cross the midline, go under the left hemidiaphragm, we see the gastric bubble and another lucency, which is air within the splenic flexure. On my way back, I look underneath the diaphragms and make sure there's no air or fluid underneath them. Also, you should note that the right hemidiaphragm is slightly higher than the left because of the underlying liver. Now we're going to look at the thorax and look at the soft tissues and bones. Okay, so we're going to take a nice long horizontal approach all the way up the thorax. We're looking for rib fractures as we go up. We're looking at the soft tissues. If this was a female patient, you would see breast shadows. So we look at the ribs as you go up here. You can see the right shoulder girdle. You have the humerus, the acromion, and the clavicle. And then you go across the midline, look at the left clavicle, the left shoulder girdle, come down the left ribs, make sure there's no rib fractures, and look at the soft tissues. Once you've done that, you're ready to look at the mediastinum. Take a quick look at it and make sure that it's not abnormally wide to suggest aortic injury. Then we're going to go ahead and look at the trachea, which should be midline. It might be slightly to the right, which is normal. You follow it down. You want to find the carina, which is right here. And the reason the carina is important is, especially with endotracheal tube placement, you want to make sure the tip of the tube is at least 2 centimeters above the carina. Then you look at the right mainstem bronchus and the left mainstem bronchus. Now we're going to go back up and take a look at the aorta and heart as we come down. So now we can see the aortic knob right here. You want to make sure that it's not calcified. You want to make sure the aortic contour is normal and not tortuous. The next hump would be the pulmonary artery. And if dilated, you would see a hump here, which would be the left atrium. And then you follow it down to the left heart border, which is the left ventricle. On the right side, you're coming down, making sure there's no abnormal contours, and then you see the right heart border, which would be the right atrium. The right ventricle occupies anterior, is located anteriorly, whereas the left ventricle is posterior. The other thing you want to look at is the heart size. The cardiothoracic ratio should be less than 50%. So you draw a diameter through the heart and a diameter through the thorax, and it should be less than 50% size ratio between the two. Finally, looking at the mediastinum, you want to look horizontally at the hilar structures, and the left hilum is usually slightly higher than the right. Now that we've finished our mediastinal search, we can go ahead and go to our lung fields. We're going to go one lung field at a time, and then we're going to do both together. So again, I start at the right base. I see the right costophrenic angle. It's very important to look here for pleural fluid. If the pleural fluid is about 200 milliliters, it should show up on a PA view. All right, and then we go ahead and just go back and forth all the way up the lung field. We're looking for any nodules in the peripheries. We're looking for any pneumothoraces, which you also make sure you check the apex, look for pleural lines, look for loss of lung markings to suggest a pneumothorax. You want to also look for any focal airspace opacities, which would suggest consolidation or atelectasis. You want to look at the pulmonary vasculature. So you look at the pulmonary vascular markings and make sure that they're nice and thin and pencil sharp and not dilated and fuzzy to suggest pulmonary vascular congestion or edema. And then looking medially, you will see these nodular radiodensities here, which are vessels on end, and that's how you know that they're not pulmonary nodules. Pulmonary nodules would usually be more peripherally shown on a chest radiograph. Then we're going to do the same thing on the left lung field, coming down. Again, looking for the same components, any densities, any opacities, any congestion, any pneumothorax, any pleural fluid. And then you're going to do both sides at the same time, back and forth, back and forth. Now, a couple pearls I'd like to point out is that if you see an opacity that obscures the right heart border, that would put you in the right middle lobe. If you see something that obscures the right hemidiaphragm, that would put you in the right lower lobe. If you see a soft tissue density at the right cardiophrenic angle, that's usually the IVC. Again, here on the left side, if something obscures the left heart border, that usually puts you in the lingular region of the left upper lobe. Something obscures the left hemidiaphragm, that would put you in the left lower lobe. So that's pretty much the search on a PA view. Now we're going to go ahead and go to the lateral view. So again, you start at the abdomen, and you're going to go posterior to anterior. You can see again that here's the dilated splenic flexure, so that has to be the left hemidiaphragm. Another trick is that the right hemidiaphragm should actually go all the way to the anterior. You should be able to follow anteriorly to the tip, because the left hemidiaphragm is obscured or silhouetted out by the heart, so it usually stops in the middle. Another trick is looking at the costophrenic angles on the lateral view. So I have another patient's lateral view here, which shows the costophrenic angles nicely. And here, if the pleural fluid is at least 50 milliliters, it should show up on the lateral view. The right hemidiaphragm is slightly higher and continuous, and you can see that it also reaches all the way back to the more enlarged right posterior ribs, whereas the left hemidiaphragm kind of goes and kind of obscures out from the heart. Another thing I wanted to point out in this lateral view is that you can see the spine very nicely, and you see the spine should get darker as you come down. If something is hiding in the posterior lung field, it would obscure, or it would cause the spine to become lighter, and then you would know that there's something hiding there. Now back to our patient's lateral view to finish our search pattern. Basically, we're going to go up after we do the abdomen and check the costophrenic angle. We're going to go up the spine, make sure the vertebral bodies are nice, have a nice height, all the disc spaces are clearly seen, make sure there's no osteophytes, no fractures. And then once you go up, you're going to come down the anterior side. You can see the manubrium and the sternum very well. Then you're going to come down the mediastinum. You can see the trachea. Sometimes you can see the esophagus. Sometimes you can see the aorta. You see the hilar vessels and all these vessels on end. You can see the heart nicely. And then finally, you can see the lung fields again. So the lateral view really helps you to kind of localize stuff that you see on the PA view, and helps you kind of put it into the right area. So now that we've gone through a nice search pattern for both the PA and lateral view, now we can go ahead and look at how we would report this. Again, it's also important that you compare what you're looking at with a prior chest radiograph and make sure that the findings are stable or changed, and it's very helpful for the radiologist to look at priors. So looking at our report, you look at the examination. It's a chest X-ray. Look at the history. Let's say it's shortness of breath. You put in the technique, which is a PA lateral view of the chest. You always look for comparisons. And then we like to report pertinent negatives. So here we'll say the cardiomediastinal and hilar silhouette is within normal limits. The lungs are without focal consolidation, pleural effusions, pulmonary vascular congestion, or pneumothorax. The diaphragms are normal in position and smooth in contour. And finally, the osseous and soft tissue structures are within normal limits. So our final impression would be a normal chest radiograph. So hopefully this helps give you a search pattern that you can practice, and hopefully not miss findings when they come up. Again, it takes a lot of experience to actually, once you make a finding, to kind of explain what that finding is. And thanks for watching.